Hi, everyone. Welcome to the GAP MASLD-MASH Community Network. This presentation is sponsored by Madrigal Pharmaceuticals. I'd like to thank you for logging in tonight. Tonight, we're going to be talking about MASLD pharmacotherapy. My name is Elizabeth Alqueza. I'm a physician assistant at Beth Israel Deaconess Medical Center in Boston, Massachusetts. I work exclusively in hepatology and with a large focus of my practice on the care of patients with steatotic liver disease. I would like to mention that as we get started, there is some interspersing of nomenclature throughout this presentation. It sometimes notes it as NASH. We all know that the new nomenclature is MASH, so just keep in mind that's the disease state that we're actually referring to. I'd like to encourage you to use this QR code to record your attendance for tonight's presentation. I'd also like to encourage you to visit the GAP MASLD/MASH Community Network to view Madrigal MASH disease state education and Madrigal Rezdiffra promotional program. So lots of really great resources on this website for mid-level providers, and I would really encourage you to check it out. So as we get started tonight, we're going to be talking about currently available treatments for dysmetabolic management. And as you can see in the image depicted on the screen, there are several approaches to the care of our patient with metabolic syndrome with steatotic liver disease. We're going to work on addressing the importance of controlling obesity, of reducing these patients' cardiovascular disease risk, and on treatments that specifically target the underlying MASH. So thinking about controlling obesity, we want to really work with our patients on goals for weight loss. We know that these patients are recommended to lose 7 to 10% of their total body weight to help reverse their fatty liver disease and begin to see some histologic regression. So very important that we're counseling our patients on diet and physical activity recommendations, that we review weight loss medications, and consider bariatric surgery in certain patients. With regard to medications, and we're going to touch on this a bit more this evening, we can be thinking about the wildly popular GLP-1 receptor agonist and the GLP-1 GRP receptor agonist. So important to keep in mind, however, when we're looking at drugs, that some of our patients do have advanced liver disease, and we need to be selective with regard to what we're choosing in terms of medications and how we're dosing specific patients. Moving into the gray box, we're also thinking about reducing cardiovascular disease risk in this patient population. So we know that in order to have steatotic liver disease, they have at least one cardiometabolic risk factor. And it's very important that we're taking a multidisciplinary approach to treating these other metabolic issues. So looking at ways to improve their glycemic control, looking at how to reduce cardiovascular risk factors, including hypertension and dyslipidemia. And I think it's important to note that a lot of our patients benefit from the use of statin therapy. It's very important in reducing their cardiovascular disease risk. And we are all accustomed to having patients referred to our practice who their statin's been stopped just because they have elevated liver enzymes. And I would really want to make all of us as providers aware that NAFLD does not increase statin risk of drug-induced liver injury. So this patient population can and should use statins. And then finally, in that gold section, we're looking at treatments that specifically target the underlying MASH, liver-directed treatments. And those can include vitamin E, except for our patients with diabetes, pioglitazone, and the newly approved Resmetirom. So thinking a bit more about our GLP receptor agonist, important to note that after food ingestion, endogenous GLP-1 stimulates glucose-dependent insulin secretion. It suppresses glucagon. It delays gastric emptying and directly acts on the hypothalamus to promote satiety and reduce energy intake. So I like to think of that one as sort of working directly in that reward center of our brain. And for a lot of patients, the use of these medications really shuts down that food noise that a lot of our patients struggle with. GLP-1 receptor agonists are analogs of the gut-derived incretin hormone glucagon-like peptide 1, and GLP receptor agonists lower blood glucose and result in weight loss. They've really been truly groundbreaking in providing a way for our patients to achieve weight loss goals. And so that's resulted in overall improved health and then also improvement in their steatotic liver disease as a result. The role of GLP receptor agonists in our hepatology practices. So as we're thinking about trials that have looked at the use of these medications, it's important to note that semaglutide was dosed at 2.4 milligrams once a week, which is the maximum dose, and successfully met both primary histological endpoints at 72 weeks. So resulting in evidence of significant MASH resolution without worsening of their underlying scarring or fibrosis, as well as significant improvement in the liver fibrosis without worsening of their MASH. So these are drugs that we are considering in our patients who are overweight with steatotic liver disease, and they are having really positive results in these patients. I think in our practice and the recommendation would be to use a higher priority in terms of who you're choosing to treat with these, as far as focusing on those patients who have sort of more advanced liver disease. So you're sort of more moderate fibrosis patients or even more advanced fibrosis, stage 2 or 3 type of a thing. It's not really indicated for patients with lean MASH. So how do GLP-1 affect us as GI providers? So as we mentioned on the prior slide, one mechanism of action of GLP-1s is the delayed gastric emptying. Our patients report it, they feel full faster, they're endorsing that early satiety, but it increases our patient's risk of aspiration with anesthesia. So if a patient has taken their dose within 7 days of a scheduled procedure, there are increased risk of administering anesthesia, and that patient's at risk specifically, as we mentioned, for the aspiration. So very important that you look into the guidelines at your specific practice location. There are some places that may actually have patients hold GLP-1s for longer than 7 days. So really important as we're ordering those colonoscopies and endoscopies and having patients prepare for these upcoming procedures or even surgeries, that they're aware of this guideline. Otherwise, our patients take the day off from work, have a ride, have done a colonoscopy prep only to arrive and find out that their procedure has been canceled. So an important practice reminder for all of us who are counseling these patients. So thinking of another treatment that's been explored in the use of steatotic liver disease is vitamin E. And in the PIVENS trial, which was a landmark study which included non-diabetic MASH patients without cirrhosis, these patients were dosed at 800 international units daily. And this study showed vitamin E improved liver histology in non-diabetic adults with MASLD. The effectiveness rate was about 43% of those patients showed histologic improvements. But there were some limitations in that not all patients responded, and we're not able to use this in our hypertensive or diabetic patients. So guidelines came out, AASLD released guidelines in 2023, which suggested that vitamin E may improve MASH in non-diabetic individuals. But our 2024 guidelines from our European societies don't recommend it as a MASH therapy due to limited efficacy on fibrosis and potential risks. So, there are real risks with the use of vitamin E, bleeding, specifically hemorrhagic stroke, and prostate cancer concerns are the most noteworthy. So really, as practitioners, I think very important to use sort of cautious consideration and really discuss these risks with a patient when considering use of vitamin E. Pioglitazone is another medication that has been looked at as well during that PIVENS trial. MASH patients with or without type 2 diabetes were dosed with a dosage of 30 to 45 milligrams per day. And this trial showed there really was no benefit of pioglitazone over placebo for the primary outcome improvement in histologic features of MASH. So there was significant benefit with the use of this medication for some of our secondary outcomes, like improvement in cardiovascular risk, but not recommended in terms of specifically trying to see fibrosis regression in MASH. And again, as with vitamin E, there are definitely some safety considerations to think about, specifically thinking of that risk of weight gain. So here we're talking about a patient population that we're earnestly attempting to achieve weight loss, and then we're recommending a medication that may result in weight gain. That usually doesn't go over super well. Also edema, bone fractures specifically in women, and a possible association with increased risk of bladder cancer. So again, as with vitamin E, sort of very careful patient selection, monitoring, really deciding if this is the right treatment option for your patient. On March 14th, 2024, Resmetirom, which is our first FDA-approved medication for the treatment of NASH in conjunction with diet and exercise, was approved. This is approved in adult patients with MASH, and specifically those patients with moderate to advanced liver fibrosis. So those are our F2, F3 fibrosis patients. This is not approved right now for the use in patients with cirrhosis, but there are ongoing trials looking at the use of this medication in cirrhosis. Also not approved for our lower fibrotic patients. So those with sort of more mild disease, our F1 patients, this is not indicated. It is a thyroid hormone receptor beta agonist, and it selectively binds to and activates thyroid hormone receptor beta in the liver. So looking at the physiological relationship between the thyroid and liver. So the production of thyroid hormones is regulated by hypothalamic and pituitary activity through TSH, or thyroid stimulating hormone. Thyroid hormones regulate many metabolic activities in several systems in the body, including the liver. And the thyroid hormone receptor has two major isoforms. But relevant to this discussion tonight, thyroid hormone receptor beta is the predominant isoform in the liver. So resmetirom is a thyroid hormone beta receptor agonist that selectively targets the liver. Its key mechanisms in treating MASH are plentiful, and they include lipid metabolism. So resmetirom activates thyroid hormone receptor beta in liver cells. It upregulates genes involved in fatty acid oxidation and lipid metabolism. So this helps break down that excess fat in the liver. It also increases the expression of bile acid synthesis enzymes, promoting cholesterol conversion to bile acids and enhancing cholesterol efflux from the liver. So it increases mitochondrial biogenesis and removes unhealthy mitochondria, which leads to increased capacity to metabolize free fatty acids. By reducing that fat in the liver, it indirectly decreases inflammation associated with MASH. And it has an antifibrotic action, which may help improve liver fibrosis by decreasing the activation of hepatic stellate cells, which are responsible for collagen deposition. So that's a lot of detail with regard to how resmetirom works. I think the take-home message is that resmetirom sort of defats the liver. So we're taking a totally different approach for this medication in that it is a liver-directed therapy. Your patient is not going to lose weight on this medication. It's not going to help with their cardiometabolic risk factors. It's going to target the underlying process and help defat the liver. So the FDA approved resmetirom under an accelerated approval pathway. And there is an ongoing phase 3 randomized controlled trial of resmetirom in NASH with liver fibrosis called MAESTRO-NASH. This trial is what led to the approval of Resmetirom, and it studied adults with biopsy-confirmed NASH and a fibrosis stage of F1B, although I will say that was probably fewer of the patients, and more commonly those patients with F2 or F3 stage disease. There were 966 patients who were randomly assigned in a 1:1:1 ratio, so same number per each arm, to receive once daily Resmetirom. So those patients were randomized to an arm where they were dosed at 80 milligrams, at 100 milligrams, or to the placebo arm. And the study really looked and is still looking at two primary endpoints at week 52. And those were NASH resolution, including a reduction in the MASLD activity score, or NAS, by greater than or equal to 2 points with no worsening of fibrosis. And the second endpoint was an improvement or reduction in fibrosis by at least one stage. So they wanted to see that your patient's underlying MASH resolved with improvement in that NAS score, and then they wanted to see that there was an improvement in the degree of damage or fibrosis by at least one stage. As we're thinking about this study, I do think it's important to touch on the safety and what adverse events or effects were experienced by the patients involved and enrolled in the trial, because that's relevant to the care of our patients as we're considering starting this medication. So diarrhea and nausea were more frequent than in the placebo arm. And as you can see, looking at the graph below, in terms of diarrhea, 33% of patients who were randomized to that 100 milligram dose experienced diarrhea. 27% who were randomized to that 80 milligram arm experienced diarrhea, and placebo was about 15%. I will say that in clinical practice and from the review of this study, diarrhea often is fairly mild and improves over the course of the first month or so. So I would try, if your patient's diarrhea is tolerable, to have them try to push through and see if it doesn't get a bit better with time. In terms of the nausea, we saw 18.9% in that higher dose arm, interestingly, had nausea, whereas slightly more had nausea at the 80 milligram dose, and then about 12% in placebo. As far as serious adverse events, they were pretty similar across those trial groups. And so what did the data show? So the data showed that Resmetirom dosed at 80 milligrams and 100 milligrams, which I'll mention is weight-based, were superior to placebo with respect to MASH resolution and improvement in liver fibrosis by at least one stage. So we saw that looking at those endpoints in terms of MASH resolution, about 29.9% achieved that at the 100 milligram dose, about 25.9% at the 80 milligram compared to placebo at 9.7%. And then in terms of fibrosis improvement, by at least one stage, we saw 25.9% at the higher dose of 100 milligrams and 24% at 80 milligrams compared to 14.2% on placebo. So that was considered statistically significant and reaching those endpoints. So practical considerations for managing MASH with Resmetirom. So our ideal patient, as I've mentioned, is that adult patient who has non-cirrhotic MASH and specifically has sort of more moderate to advanced liver fibrosis. So our stage 2 to 3 patients. And it's only improved in conjunction with diet and exercise. So Resmetirom is going to target that liver pathology, whereas the diet and exercise and the goals of weight loss is going to help with regulation of that metabolic syndrome and decreasing those cardiovascular risk factors. Some additional practical considerations, and this is a helpful slide that if you want to take a screenshot for your own practice may be helpful, is to think about there are some drug-to-drug interactions. So that first column has a list of medications to completely avoid or to consider changing if the goal is to start the Resmetirom. The middle column has a group of drugs that are tolerated but with the resmetirom dose reduction. So importantly, Plavix is a medication that some of our patients may be on. So, important to know that you would need to reduce that resmetirom dose. In that right-hand column, there are medications which are at risk of increased exposure due to resmetirom. And then I'd like to highlight the bottom right box where it discusses the maximum statin doses. So we started this talk by noting that statins are encouraged in this patient population, but if we're going to add resmetirom, there are some parameters of dosing. So pravastatin and atorvastatin, maximum dose should be 40 milligrams daily. And simvastatin and rosuvastatin, the maximum dose should be 20 milligrams daily. So as I mentioned, the MAESTRO-NASH trial is ongoing. We're learning more as they're continuing the study. And there's still some pieces that as providers we're looking to gain guidance about. Likely we're going to need to restage our fibrosis with the use of non-invasive tests, specifically thinking about that transient elastography, your MRI, proton density fat fraction, use of the CAP score to measure steatosis, and the proprietary lab test called ELF. There are expert panels who are currently working on cut points and also the intervals at which we should be performing these tests. I would encourage you to reference AASLD, did release some practice guidelines, which are, the ones that we're referencing for the time being, which do have some intervals in terms of how to use the non-invasive test and safety monitoring for patients who are starting resmetirom. There's a nice table that can be referenced. And so a few questions remain. We're trying to determine insurance coverage. Is widespread resmetirom use going to be feasible in terms of coverage issues? We're looking at the intervals at which to stage and perform monitoring lab tests. We also are trying to determine what is the duration of treatment, and all of these pieces are evolving as the study is ongoing. And is there the possibility the patient could stop the medication altogether once some of those endpoints have been met? So the other piece is that there are multiple agents currently in clinical trials and will likely have more options in the near future. So it is an exciting time as providers of these liver patients with MASH and MASLD. And I think that we're all going to find in our own practice that there will be additional options in the future. So thank you for attending this talk, and I would be happy to answer any questions if you have any tonight.